Remission doesn't mean cure. It just means there's no evidence that the disease or that the vasculitis is active.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.
Hi and welcome to Diary of a Kidney Warrior podcast. I'm your host, Dee Moore. This is the Kidney Health podcast that shares real stories and expert conversations to educate, empower, and inspire people living with kidney disease and those who support them. Welcome to part 2 of my conversation with Dr. Lauren about vasculitis and kidney disease. Today, in part 2, we discuss treatment, including steroids and immunosuppressant therapies, whether kidney function can recover after vasculitis, dialysis, remission and relapse, and living with the long-term condition. If you haven't watched part 1 yet, please do click the link and watch part 1 now. I hope you enjoy this conversation. Let's begin. This episode is for educational purposes only and should not replace personalized medical advice. If you have any concerns about your health or symptoms discussed in this episode, please speak with your healthcare professional. What does treatment actually look like? Can you walk a newly diagnosed patient through what to expect?
Yeah, so treatment can feel really overwhelming for new patients. So you've just received this diagnosis of something that you've probably never heard of before, and then we go straight into talking about treatment. And often the nature of vasculitis is the treatment you need. You need it pretty quickly, really. So it can feel really overwhelming and a lot of information coming at you all at once. I think for a lot of patients, they feel very overwhelmed by the number of tablets they may start taking. So you may go from nothing to 5 up to 10 tablets almost instantly. And I always reassure patients that our hope is that you start up here and things will come down as the treatment gets under control. Now, again, vasculitis is a broad term and there's different types of vasculitis. But if we use ANCA vasculitis as an example, we tend to split it into 2 main parts of the treatment. So we give something called induction treatment. And that is really just to get on top of the vasculitis and get the condition under control as soon as possible. The second part is then the maintenance treatment, and that is the part of your treatment that keeps the vasculitis under control longer term. But if we focus on the induction treatment, because this is often where things can feel quite overwhelming initially and you've not yet had your chance to sort of get your head around things. This is often started on the ward if you're very poorly, like I say, as sort of urgent treatment. And there's a few different ways we approach it. So the first thing we want to do is reduce all of that inflammation that I keep talking about, all of that activity that the vasculitis is causing. We want to make that quiet. Now, the way we tend to do that is to give steroids. Now, this tends to be initially maybe a higher dose of steroids given through a drip, and then tablet steroids, often called prednisolone. And this is just to reduce that inflammation. Sometimes if your disease is very significant and has caused quite significant kidney failure, or in those patients who have this rapidly progressive kidney disease, then we will try and remove some of those proteins, those ANCA proteins that are within the blood, because it's likely that they're getting clogged up within the kidney filtering stations and causing more inflammation. So that's something called plasma exchange, and that's where we take the blood out of the system, we clear it of all those proteins and we put it back. Now, not every patient with vasculitis needs that. It's really only done in severe cases. But if we think that that's needed, then that's part of the treatment. And then what we're also doing alongside that is trying to make that immune system quiet. So we're trying to switch off that immune system that's gone a bit rogue and is causing all the problems. And the way we do that is we give something called immunosuppressive treatment. That's commonly given via a drip through the arm, and in some cases we can give it as tablet treatment. So that's really how we approach the initial treatment. So reduce the inflammation and trying to switch up the immune system. And then if we need to remove anything, we can. And then once the treatment has got the vasculitis under control, then we can think about treatments to keep people in remission longer term.
So when you were explaining about these different treatments, is that where rituximab and medications like that come in?
Yeah, exactly that. So steroids are the most commonly used treatment, like I say, and I think my experience and what people have described who have had steroids is it's a really love-hate relationship. You know, you felt poorly for so long, often months. You finally get a diagnosis, you're given steroids, and they're a bit of a wonder drug. They make people feel better quite quickly. Turning off that inflammation really can make people think, oh, I'm feeling much more like myself. But unfortunately, they come with a lot of side effects. And that's, that's the hate part of the relationship, that the side effects associated with steroids are very significant. So we don't leave our patients on steroids as long as maybe we would have done 10, 20 years ago. And now we have other treatments that we can give. So cyclophosphamide is a form of treatment that we often give in patients with vasculitis. It's actually a form of chemotherapy that's been around for a very long time, but it's really effective in vasculitis, and it helps stop those proteins being formed that are causing the problem. Now, these can sometimes be given on its own, or it can be given alongside the rituximab, which you mentioned, and I'll speak about in a second. And that tends to be given every 2 weeks. And how long we give that really depends on the severity of the kidney problems. And we keep a close eye on patients because there are, again, side effects associated with that. Rituximab, you mentioned, is a slightly newer medication, although we've had it for many, many years now. And again, is very effective in vasculitis and is used probably most commonly now in most centres. And that works by reducing what we call B cells. B cells are within the blood, and they're part of the immune system that causes and produces this abnormal anchor protein. And they play a big role within the immune system. So we tend to give rituximab to, again, just suppress the immune system. Now, you'll normally have rituximab first dose and then followed by a second dose 2 weeks later. And that stays in the system for about 6 months. And then you may need some top-up doses every 6 months after that. But again, there's sort of variability in this in terms of how severe your vasculitis is and other parts of your health and any other sort of medical issues and things like that. So these are the treatments that we tend to give at the start. There are tablet immunosuppressions that we can also use. So there's lots of different medications we use within vasculitis, but these are the common ones that you'll see prescribed most patients will have experience in either talking about or having received. And I think from a patient perspective, what we probably don't do very well in that initial stage is explain, the administration of these and how sometimes how overwhelming and scary that can be. These bags often come sealed with a toxic sign on, and you think, oh goodness, why are you giving that to me? And I think we sometimes maybe don't explain the importance of these medications or appreciate how scary it can be from a patient perspective to receive these. So I would encourage anyone that has concerns or is apprehensive or is scared is, just ask the nursing staff, the doctors, the healthcare professionals that you have access to, just to say, what is this and the purpose of it and other things, just to make sure that you feel like you properly understand the treatment you're receiving.
And how long are the treatments typically, how long does it typically last?
Yeah, so I mean, this sort of induction phase can normally takes quite a few months to try and get the vasculitis under control. Once it's under control, then we talk about the maintenance phase of keeping it under control. And often we can continue treatments for sort of 2 to 4 years after things have gone quiet. But that can vary, and it often depends on other things like relapses and things like that as well.
I just wanted to touch on what you were saying about steroids and the side effects of steroids, because speaking personally, I know how horrendous the side effects were for myself. And with this podcast, I like to explore the good, the bad, and the ugly. But I do like people to be prepared for what may or may not happen. So just going over that just a little bit more. So what are the side effects that patients need to prepare for, especially around steroids?
Yeah, and I think that is, your experience is that of a lot of people with steroids. And again, I think this sort of love-hate relationship that people have with steroids is so true, because you have this initial few days of feeling great, and then the side effects for most people start to kick in. I think I'm always honest with my patients. I think initially, often the commonest things we see, or the most problematic, tend to start with things like you might not be able to sleep. So insomnia is a big part of it. Steroids can make you feel quite wired. And we often give them in very high doses at the start. So it's not uncommon that people say, I can't sleep now you started these. We also notice the blood pressure goes up, and we talk about blood pressure being a big part of kidney medicine and trying to control blood pressure, and steroids can make that very challenging. People with diabetes or don't even have diabetes can experience high blood sugars, and that can become challenging to manage. Those are some of the more immediate issues. Then comes things like weight gain. And I think for most people that have taken steroids for a long time, the weight gain is really significant and can't really be overestimated how significant that is, because the problem with steroids is that they will increase your appetite and they increase the amount of weight you gain. And this tends to be in the face, often around the tummy, and sometimes at the back, sort of the back of the neck. And it doesn't matter what you eat. And I have patients saying, oh, I'm not eating very much, or I'm trying to reduce what I eat and I'm still gaining weight. And that is the nature of steroids. And it can be really, really challenging. Infections are another big part of steroids. So steroids will increase your risk of infections. They'll increase things like generalized weakness, muscle weakness. They increase your risk of osteoporosis. They can upset your tummy, give you heartburn. The list goes on. There's so many adverse effects of steroids. And I feel part of my PhD in vasculitis was looking about how we can reduce the amount of steroids. And I feel positive because a lot of the work that is happening within vasculitis and other conditions where steroids are being used is looking at how we can use different medications to try and reduce the amount of steroids we're giving patients, because we know that these side effects are reduce people's quality of life. They cause other health problems, which you don't need. They can make other issues challenging. So part of what the vasculitis community is doing across the globe is looking at ways in which we can reduce steroid exposure for patients. And that's a really big part of the work we're doing. I think just to add to that, the one thing I will reassure patients on is often, as I mentioned, we start at these high doses of steroids and work to reduce that. So we do rapidly reduce the steroids now a bit quicker than maybe we used to. And so hopefully those side effects are shorter lived if we can get them down. So that's always been the aim is I try and reassure patients that we'll get the steroids down as quickly as possible to reduce those side effects.
Can kidney function recover after vasculitis damage, or is it a case of what's lost is lost?
So it's possible that kidney function can recover. Again, it often depends how much damage has been done, essentially. So going back to what I mentioned about that biopsy, sometimes we can look and say, oh, actually, this is a lots of activity that could be treated, versus maybe actually this is mainly scarring that is irreversible. But there are cases with patients who present with worsening kidney function and may even need some dialysis initially, that with treatment over the coming weeks, we can actually get people off dialysis. That's not uncommon, that is possible. But it really depends on how quickly we can start treatment. And again, just going back to that sort of time is kidney, if we can start treatment promptly and try and reverse all of that inflammation, and try and get on top of the vasculitis. And there is hope that sometimes we can improve the kidney function. Not always, but sometimes. And a kidney biopsy is often really helpful in guiding us on that.
I think people would be very surprised that you could start dialysis and actually be able to come off it. So in the context of vasculitis and those dialysis sessions that you were talking about, is it that you're kind of cleaning out the buildup of these proteins in the dialysis process, and by doing that, that's what helps the kidneys to recover? Am I right in my thinking in terms of that?
No. So the dialysis doesn't clear any proteins, but what the dialysis does is allow us to focus on the treatment. So the dialysis will take the pressure off the kidneys. We can try and get things better, maybe from a fluid perspective, if you've got fluid building up, if the blood pressure is very high, if you've got other toxins that are accumulating because the kidneys aren't working. We can try and optimize things from that perspective. Sometimes the treatment for vasculitis takes a while to get into the system and get working. So it buys us a bit of time more than anything, rather than necessarily clearing any of those proteins. There is a way in which we can do that, and it's similar to dialysis. And as I mentioned earlier, that's called plasma exchange. It's a very similar machine where the blood comes out, gets cleared of those proteins and goes back. By all intents and purposes, it's a similar process, but the dialysis wouldn't do that, if that makes sense. But plasma exchange itself can be helpful in some cases to do exactly what you just described. And often those things can be a bit confusing for patients as well, because by all intents and purposes, they look the same. And it's that process of cleaning the blood. Some people need plasma exchange and dialysis. And so, they can occur together as well. So you can feel like you're on a machine for days on end, but the hope is that we can try and recover the kidney function.
What does remission actually mean for a vasculitis patient?
So remission is basically when there's no evidence of disease activity. So it normally means that the treatment has done the job to get the vasculitis under control and not causing any damage or problems within the body. I think the difficult thing about vasculitis is there isn't a cure. So remission doesn't mean cure. It just means there's no evidence that the disease or that the vasculitis is active. And I think that's really challenging, because when you say to someone there's no cure for something, that hits you significantly. It's really difficult to get your head around the fact that you're going to live with a condition for the rest of your life. What we try and do with our treatments is keep the vasculitis in remission for as long as possible. And that's the main aim of what we do. But vasculitis is what we call a relapsing remitting condition. It does relapse. And relapses are more common with different types or different, subtypes of vasculitis. Within ANCA vasculitis, some of the research suggests that about 30 to 50% of patients with ANCA vasculitis will have at least one relapse within their first 5 years. That's a significant amount. So I think it's important that we're honest with patients that relapse is possible, in some patients probable, to be mindful of what that means for them. I do tell patients, it's really important that we get to know each other, that we build a rapport, because you're going to be seeing lots of us. We rarely discharge people from our clinics. But what we can do is keep people with vasculitis in remission and keep them well for as long as we possibly can. Now, if we think about the way that research within kidney medicine and vasculitis is going, I think the stuff that's being done at the moment is incredible. I think let's watch this space for what the future of vasculitis looks like. But there are lots of novel therapies coming forward, and it's maybe one day we'll have a cure for it. At the moment, we don't, but we do have great medications now that can keep people living with vasculitis keep them living well for a long period of time.
What are the warning signs of a relapse?
So I think for a lot of patients, they tend to present with similar symptoms that they had at the start. So it may be you think, oh, I remember having this, a few years ago, or this feels familiar. The hope is that once you've had a diagnosis of vasculitis, once your pathway to getting treatment is much quicker because you are being seen in clinics, you understand the condition, and you know what potentially to look out for or what you've had previously. Some people don't necessarily get any warning signs, but the purpose of seeing patients frequently in clinic is that we could be keeping an eye on blood tests, on urine tests, and sometimes we can notice a sign that maybe things are potentially starting to brew, and we can nip it in the bud early. But again, the symptoms can be variable. Like I say, most patients tend to present with similar symptoms they had before, though not always.
Are there any lifestyle factors, diet, stress management, avoiding infections that can help protect against a relapse?
Yeah, great question. So vasculitis, we know is quite associated with the risk of cardiovascular disease. So people with vasculitis are more at risk of having cardiovascular complications. And by that, I mean blood pressure issues, heart issues, potentially things like strokes. So it's really important that people understand this, and that we focus on things like blood pressure management, cholesterol management, weight and blood sugar management. So all of these things, all of those aspects of people's care is really important to keeping them well. Smoking is a big one, so stopping smoking. We know that in different types of vasculitis, smoking can trigger vasculitis. So in things like anti-GBM disease, which is a different type of vasculitis, smoking can cause relapse within the lungs. So I always advise people, if they are smokers, to seek any smoking cessation help and therapies they can to stop. Avoiding infections as best you can is really important. So hand washing, staying up to date with vaccinations, seeking medical advice if you're poorly, again, is really important. And I guess one of the other things is making sure that you're taking the tablets that are prescribed and attending your clinic appointments, because sometimes, understandably, you've been through this journey, you're starting to feel better, you've got some normality back, tablets become less of a priority, clinic appointments become less of a priority. But the problem is that those tablets are potentially keeping the vasculitis in remission. And if you miss one day, that becomes 1 week, that becomes a few months, your risk of relapse is much higher. So it's just about making sure that you're living as healthy a lifestyle as you can, that you're changing those factors that you can, be that weight, smoking, blood pressure, and that you're taking the medications prescribed.
So in terms of those medications that you were talking about, how long do patients typically remain on those maintenance medications?
So once we've achieved what we call disease remission, so once everything's settled down and there's no evidence of active vasculitis, and we typically say that we'd want to keep your medications for potentially 2 or even up to 4 years. Some people need it longer if they've had relapses in between. It really depends on other factors like how well they're tolerated, if you've had any adverse sort of effects from the medications, and other sort of factors, your other health conditions and things. But we do say to patients, you're bedding in for a couple of years worth of treatment once you've got vasculitis.
If vasculitis caused kidney failure, does having a history of vasculitis affect transplant eligibility?
So any vasculitis patient that progresses to end-stage kidney disease, needing dialysis, or if the kidneys aren't working and we don't think they're going to improve, I think anyone well enough for a transplant should have a kidney transplant, and it's a good option for patients. There's no clear guidelines really specifically around transplanting patients with things like ANCA vasculitis. The general consensus is that we wouldn't transplant anyone that had active vasculitis, and that seems very reasonable. We'd also want people to be free of any infections. But when the optimal timing is for vasculitis patients to be transplanted is a little less clear. So some centres suggest that patients have to have a negative ANCA antibody, what we've mentioned before. Some recommend waiting 12 months from diagnosis or 12 months from being in remission before listing patients for kidney transplant or then receiving transplant. So There is slight variability in how centres choose to manage their vasculitis patients. But if you've got a diagnosis of vasculitis and you need a kidney transplant, then there would be no reason why you wouldn't be able to get one, providing you're well enough and met the other criteria.
So can vasculitis return in a transplanted kidney? Is there a risk to that transplanted kidney?
Good question. So vasculitis can occur after transplant. Doesn't always occur in the kidney. That's the important thing to say. We know that it can come back in other organs in the body, but not always the kidney. So vasculitis can occur in the transplanted kidney, but it's not super common. And what we tend to see is most patients don't end up losing their kidney as a result of vasculitis coming back into the kidney. And part of this is probably the fact that you're on anti-rejection medications, and that sort of keeps the immune system quiet by the nature of keeping the risk of rejection down. So yes, it can reoccur. It's not very common, and it doesn't often lead to the loss of the kidney. But again, there are variations.
What do patients on the kidney transplant list need to know about managing vasculitis while they wait?
So I think that the key thing is that we need to keep the vasculitis in remission. So that's often the key part of things. Again, as I mentioned before, good adherence to medications is really important. Improving your cardiovascular health, making sure that your BMI is optimal so that all of these risks associated with transplantation are reduced, avoiding things like infections where possible. It's really about being as well as you can be in that period where you're waiting for either the call for a kidney donor, or if you're being worked up for a live kidney transplant, and just making sure that vasculitis stays in remission. And part of that is about just being, as a patient, controlling the things you can control. Often is the case with things like any chronic condition. You feel like a lot of things are outside your control, and part of that is true with vasculitis as well. You can't predict if the immune system's going to have a relapse, but doing things like taking the medications, making sure your blood pressure is optimally controlled, your blood sugars are well controlled, all help in optimizing yourself for a transplant.
What does day-to-day look like for someone living in long-term vasculitis remission?
Well, I would hope that after someone's achieved remission, their life starts to resemble that of what it did before they had their diagnosis, and they're feeling better and well and regaining some sort of normality and routine. I think it would be naive to think that things just go back to how they were to start with, not least you're now living with a chronic condition and all the things that come with that. So I think if I was being honest with patients, the key things I would say that maybe would change, or what it would look like, is a lot more medications, probably a lot more tablets to take, a lot of clinic appointments, scan appointments, follow-up appointments of various kinds. It does sometimes feel, I think, for people, a bit of a part-time job, managing hospital appointments, juggling all the different commitments, medications, timing of things. And that is a part of living with a chronic condition. I think fatigue is a huge thing, and one that we probably don't fully understand across all parts of general medicine. But fatigue is a really big part of living with a chronic illness. And sometimes it feels frustrating for patients, but also for doctors, clinicians, that we don't have a good answer for that or a good treatment. I'd love to be able to prescribe a pill that addresses people's fatigue, but that's not what we can do. Often people feel like they have to sacrifice one thing to do another. So I don't know if you've ever heard of the spoon analogy. Some people use that quite commonly, and that can be helpful for patients to understand. You start the day with a finite number of spoons, and you spend them on different things. And I always encourage patients not to get into this role of using tomorrow's spoons and then feeling like you need this period of payback where you're then catching up and just taking rest. So I think addressing the fatigue element and managing that the best way possible is really important, and is a routine part of living with vasculitis, even once it's in remission. Sleep and medication side effects are also a common part of that. So it's, even once you're in remission, there are still, obstacles and barriers to overcome. But the hope is that there are lots of things that you can start doing and regaining some sense of, yourself and routine as well.
Are there things patients assume they can no longer do that they can actually still do?
Yes, absolutely. So I've talked loads about how there's risk of infection with immunosuppression, and understandably people then get really worried about going outside the house, doing nice things, crowds and things. And I think it's really important that patients know they can still do that. You don't become housebound because you've got this condition. It's about modifying your risks. So where possible, hand hygiene, masks, reducing your risk of infection, but it doesn't mean to say you can't go out and do things. Going on holiday is another big one. So there are considerations. You do need to think about medication supplies and insurance, vaccinations, timing around treatment, but you can still go on holiday with vasculitis. Exercise is another one. People become a bit scared of exercising or don't know if it's going to make their kidney disease worse. And I always encourage people, it's really important to exercise. Any cardiovascular activity will be important for your health, but also mental health. The endorphins you get with exercise are really important. If you have been on steroids, then again, all of the sort of strength training or improving muscle strength, bone density, super important. So you can definitely exercise. People ask about work as well. Can I work with this condition? And my answer is if you feel able to. Often it's about pacing, it's about flexibility, workplace adjustments, and any of your doctors or healthcare professionals should be able to write letters of support if you actually need a period of working from home or flexible working. But if you feel able to and you want to, and often patients through this vasculitis journey have had a long period off work, maybe even before they've had their diagnosis. So again, if you feel able to, we would support that.
So today, Dr. Lauren, we have talked about vasculitis and kidney disease. We've looked at what vasculitis is, the treatment, what remission is. We've looked at vasculitis and kidney transplant, and we've looked at the reality of day-to-day life with vasculitis. What is your final word of encouragement for the listeners and people watching?
I think vasculitis can feel really all-consuming, completely overwhelming, and a bit of a minefield when you start with it. However, there are people there that can guide you through it. Please ask for information if you're not sure. This will become an important part of your life, but not your complete life. And just because you have vasculitis doesn't mean it needs to define your whole identity. And that's true of kidney disease or any other illness as well. It is part of who you are, but does not define who you are. That is what I always say to everyone living with any chronic illness. There's a huge amount of variability in vasculitis, so it's really important that you understand your vasculitis, what your condition is and the treatment you require, because it may be different to someone else. Often I say things that try and break it down. So part of this is about adapting to potentially a new way of living. It's about pacing, so pacing yourself, taking things as they come, planning for the future, your next treatment, transplant or other things, and then shared decision making. This is your body, they're your kidneys, it's your condition, and any discussions or decisions made should be with you and your healthcare professionals so that you're happy, that you understand what the treatment you're receiving is for and where things are going. So this is always a shared process. Those would be my take-home points for anyone that is starting their journey or living this experience. But please ask, because it is a minefield, but we can potentially signpost you to the right information. I think just to conclude, if you've received a diagnosis of vasculitis, you're receiving treatment and you're potentially in the remission stage, it really speaks to your resilience. This is such a journey. It's a long journey. This is a marathon, not a sprint. And like I say, be in a vasculitis clinic for a long time, and it takes resilience to do that. So understanding that you have come through this and that you're resilient enough to withstand all of the things that we've thrown at you is really important and shouldn't be undermined, and patients should take a sense of pride in that.
Thank you so much for joining me. Thank you so much for breaking down this information and making it so accessible I know this is going to help so many kidney patients out there. So thank you so much. Thank you for joining me.
Oh, thanks so much for having me.
Thank you for watching. I hope this conversation helped you better understand vasculitis, its treatment, and what it could mean for your kidney health. If you found this episode helpful, please like, comment, and subscribe, and share it with someone who may benefit. Until next time, take care and choose to live.
Diary of a Kidney Warrior podcast in partnership with Kidney Care UK, sharing faith, knowledge, hope, and love.